Why did the mom-to-be go to the spa during pregnancy?
Oh, so many reasons. But what were you thinking?
Yes, there's a lot of reasons, but to make sure she was pampered before the Pampers.
This is STIRRUPS, Candid Conversations in Women's Health, the podcast where we answer your burning questions and discuss the evolution of women's health through every stage of life. Join Dr. Randolph Scott and duly certified women's health nurse practitioner and certified nurse midwife, Kerry Autry, as they discuss the unique health concerns women face and share expert advice to assist you on your journey to maintaining your health and wellness. If you're looking for informative discussions, tips from qualified professionals, and a community dedicated to women's well-being, then you're in the right place.
I think we just made a plug out for Pampers. There we go. All right. So with that in mind for us, let's get into what to expect when you're expecting. I'm sure there's a book out there for you to read about that, but we're going to put it a little more personal so that you can listen during your car ride and figure out all the things that you need to know for your prenatal visits as they are going to get underway for you. So, Kerry, a patient gets that first pregnancy test. What do you think the next step should be for?
Well, hopefully you celebrate. And then you should probably reach out to your doctor to figure out what makes sense to get you into the office, because we bring people in at different points for different reasons, right?
Yeah, different offices will work differently, and some have some protocols that they go by. But with our office, we're always happy to see patients right from the beginning, at least give them some idea about where things are and perhaps where things may be going for them. And so 5 to 12 weeks, that
pretty
really,
broad.
that's a long stretch.
It is.
We'll compartmentalize that, especially for those first couple of visits. What should you expect at that first visit, Kerry?
Well, you should expect that first visit is going to be a little bit on the longer side for sure. And you want to kind of think about your medical history before you come in, because there's going to be a lot of questions about your medical history, and even things that may seem irrelevant to you, we may find them pretty significant. Sure. So definitely you would like to set aside a good amount of time for that visit. If you're taking any prescription medications, make sure that you bring those in with you. And I do want to say, I always, as much as we can get this message out there, once you get that positive pregnancy test, please don't stop taking all your medications. Yeah. Talk to us before you just stop taking medications, because some of them, or most of them, in fact, will probably keep you on and may need to adjust.
Yeah, the excitement of the pregnancy, I find that it's a huge motivator. It's a time to really start afresh, and sometimes you do take away things that certainly can be helpful to you during the course of the pregnancy and may have very little impact. So you're right. It shouldn't be a cold turkey kind of stop, and some medicines require that there's a taper. So for our patients, we want them to give us a call if there's any questions with that, and so that they can do it appropriately. And then we switch some things if necessary. Sometimes it's a class of medicine that you want to switch to that might be a little bit more helpful for patients.
But remember, use us.
Yeah.
Lean on your providers and ask those questions. You don't have to make those questions. You make those answers, come up with those answers in a vacuum. And
you're right about the, medical history. Not only knowing your history, but your family history is important too for some of the testing that we'll do.
And your partners and their family history. So it really is a pretty extensive history.
Right. So the more information, the better in that regard. So not only history is important, of course, the examination is important, and then the testing. It's a lot of testing.
It's a lot of testing at that first visit. Please eat something before you go.
That's right.
Please drink something before you go. It is a fair amount of blood work. Yeah. There's urine tests that we have to do. And people will often ask, because they feel like they're sitting in that chair getting blood drawn for quite some time, what we're testing, because it's a bit.
Yeah, it's a lot of testing. Kerry, do you have to be fasting during that testing period?
No, most of our patients already are, because they don't feel great. But it's better if you can eat something.
Right. And the nausea bug, if it hadn't hit you, testing is quite a bit. And so we actually do encourage patients to eat before the visit. And so you're right. Testing can be important, but getting through the testing is even more important. And what are some of the things that we would test for during that visit?
I always tell patients that we are testing for anything under the sun that could possibly impact your pregnancy, because if we know it's there, we can manage it. So we test, everything from your blood types to your blood counts. We look to see if you're immune to certain things. We check for all the sexually transmitted infections. Depending on offices and their office policies, they may also be doing a routine drug screen.
This is correct. And so the other thing is sometimes patients forget with that particular visit, how about urine sample?
Oh, most certainly.
Yeah, that's a big one. So, a lot of patients will go to the bathroom before their visit and then can't leave the urine sample, which is also important for the testing that we would do. After the blood testing, or maybe even before the blood testing, usually that first visit will certainly incorporate an ultrasound.
Mm-hmm.
The first ultrasound is actually, it's a time to help us figure out exactly how far along you are in the pregnancy. The routine calendars that most patients will use to kind of date themselves is usually based upon a 28-day calendar.
Right.
And if your cycle doesn't fall into that, then that's going to change the dating, perhaps, of where we expect your due date to be. And so the ultrasound very early on is important to help establish that.
And that can be stressful for some patients when we're changing due dates. So I think it's important for patients to understand that it's something we do very often. It's not unusual to go in and have your provider tell you that your due date's off by just a little bit. Yeah. For anybody with a longer or shorter cycle, or there's a lot of things that go into it, but it's definitely not a cause for concern just because we change your due date.
That's right. Especially with the first ones or the first ultrasounds that you have. It really helps set the baseline for you in terms of what the expectation would be going down the line for you. As you move more forward in the pregnancy, the ultrasound is not as accurate because genetics become more of a factor in terms of dating experience. But the earlier the ultrasound, the better to help figure out exactly where things are going to end or perhaps may end for you. How accurate is that due date, though, Kerry?
Yeah. I know, right?
Yeah.
It's always feels like a bullseye on the calendar, but it, in terms of when we actually expect the baby to come, it really can be anywhere from several weeks before that date to several weeks after.
That's right. So it's an approximation. And we want to stress to patients that approximation, only 5% of patients actually deliver on their due date. 5%. That's it. And so it's really approximation. So we want you to be flexible about what that means for you. And so we try to get you in the ballpark, but very rarely do we hit it. Yeah, very rarely. So just have that understanding that things don't always necessarily go down at the due date experience for you. And so this is also a great time to discuss just about anything that you want to discuss during the course of the pregnancy. Now, it might be a little too early for the birth plan, but those questions are not out of order as well. And so what about the genetic screening test here?
So we do offer genetic screenings, and most offices will offer genetic screenings. Usually the first one is right around 10 weeks. It has to be after 10 weeks. Mm-hmm. And we usually offer two sets of screening at that point, right? There's the carrier screening to see if you, the mother, is a carrier for several recessive genes. Usually cystic fibrosis and spinal muscular atrophy. They're recessive traits, so you could be a carrier and not have any idea.
And then the other one is, the very generic name for it is a non-invasive prenatal test, and it's really non-invasive. Mm-hmm. It's just a blood test. There's no needle to the abdomen. There's no risk to the pregnancy to collect this information. And what we're trying to look for is really chromosomal abnormalities. Yeah. The primary one that is really focused on in that particular test is Down syndrome, which is an extra chromosome 21. But that non-invasive prenatal test will also test for extra chromosome 13 and 18. And we always get patients who want to know what they're having, and that test is certainly valid to help you make that determination. Now, how accurate is the test in determining sex, Kerry?
Reasonably. It's not bad, actually.
Yeah. And the test is fantastic.
Yeah.
It's about as good as any test that you can get. 99% accurate. And so I don't tell patients go start painting the rooms just yet. The anatomy ultrasound can be very helpful. I've seen hundreds, probably thousands of these tests done. I can count less than one hand when I've seen it actually be wrong. But there are times.
Definitely makes us sit up and notice when they're wrong.
When they're wrong. That's
unusual.
right. So we go back, discount, double check, and all that good stuff. Yeah. And when we don't see it going quite right. And so what are the signs of when patients should actually come in, perhaps even earlier than what their scheduled appointment would be?
So in the first trimester, the things that should send you into the office are maybe a little bit different than later in pregnancy. But I would absolutely want you to make a phone call to your provider, at least if you're having any kind of bleeding. Even if it doesn't seem like much, it's at least worth asking the question. A little bit of mild cramping is actually very common and not necessarily a cause for concern. But severe pain or back pain, you should be making a phone call.
Yeah, I agree. Those are times where we don't necessarily want to have things linger. We understand that this is a very exciting time, but can also be anxiety provoking as well,
Absolutely.
Especially when you're figuring things out and you don't know whether things are going well in the pregnancy. So those are some great tips in terms of coming in. But there's another one that is quite common, is that morning sickness. Sometimes it's morning, afternoon, nighttime sickness. It's all of the above.
Yeah.
And we try to really get you to a point where you can keep some things down. It's not as important to be able to eat what you want to eat. There will be some food aversions, some things that perhaps will stick with you a little bit better than other things. But the primary focus, at least in the first trimester, is make sure that we keep you hydrated as best as possible.
Right.
So even if you're not able to eat, if we can keep some fluids down, that usually goes a long way for the first trimester. Now, usually first trimester, that nausea bug is less of an issue. As you get into the second trimester, things start to get better.
Yeah.
So second
I
trimester.
always tell people, I'm like, you know what? First trimester, you just kind of feel low-key like you got hit by a truck all the time. Like you're just tired and achy and just feel off. And that's really normal. So I'm like, at this point, like whatever sounds good, if that's a milkshake, then have a milkshake. We'll worry about broccoli later. Yeah. Just get fluids in, get some calories in, protein if you can.
That's
and we'll
right.
just get through.
There's nothing balanced about it, right?
No. We'll get the broccoli in. It's just the first trimester, you just got to get through it.
Right. All right. That leads us to the second trimester.
Yeah.
And so now we've gotten through the rough part.
Hopefully.
Hopefully. Sometimes you're right. Things linger, and they can linger really throughout the entire pregnancy in terms of some of these issues. But second trimester, things usually turn the corner. Things are a lot better. And so.
To the point that it worries patients, right?
Right. You're looking for a sign.
Well, you feel so bad. And then one morning you wake up and you're like, oh, you know what? I feel okay. And then you're like, actually, I feel pretty good. Yeah. Like, why do I feel so good?
Too good.
I'm pretty sure I'm still pregnant. Like, I feel like I would have noticed if I'm,
right.
And patients really get concerned about it. So I'm like, you know what? Always make a phone call. If something's got you worried, make a phone call. Come on in. But it's not unusual to wake up one morning and actually start to feel really good in the second trimester.
Yeah, and sometimes it's instant. It's an instantaneous sensation that you'll have. And it leads you to wonder. But you're right. If there's any question marks, hey, give us a call. We'll be happy to have you come in, check things out for you, let you know where things stand. But second trimester really will take you through 14 weeks until you've completed 27 weeks. And so how frequent are patients being seen at that time, Kerry?
So first trimester can be pretty unpredictable, right? Because it depends on when that first visit is and genetic testing that has timing. So the visits can be sort of sporadic in the first trimester, sometimes as often as every 2 weeks. Once we get you to that second trimester, you should expect to be in the office every 4-ish weeks.
Yeah, I think timing-wise is important in terms of when you come in and what your follow-ups are. But every 4 weeks is certainly reasonable to just kind of track and monitor the progress. And so let's say a patient comes in at 16 weeks, Kerry. What should she expect at that visit?
It's a very good question, because very often that 14 to 16 week visit is the first time that you've come in and you didn't just get an ultrasound automatically. And people can be really frustrated by that. So it's kind of good to just know that going into it. I'm usually by 14 to 16 weeks, we can just get a heartbeat through the belly, which is how we get the heartbeats most of the pregnancy. There's a few other times when you'll have an ultrasound, but most of the time, if we can use that handheld Doppler and get the heartbeat through your belly, that's how we do it. Yeah. The other thing we're always doing is checking where the top of that uterus is, right? Because the uterus, we expect to find the top of it at different points during pregnancy. And if it's not where we're expecting it, that's reason for us to kind of start taking a bigger look, because the uterus isn't going to grow if the baby's not growing.
That's right. That's exactly right. And so setting the expectation, I think, is good, especially in the second trimester, because you're right. No ultrasound? What? We get that question all the time. What is this? No ultrasound? I didn't know there was such a thing. But yes, visit-wise, to set the expectation, standard of care really only requires 2 ultrasounds during the course of the entire pregnancy. I know that's a lot of maybe unknown detail in terms of the pregnancy, but really a pregnancy really only requires 2 ultrasounds, one in the beginning to establish the dating, and then your second trimester ultrasound, which is the bigger of the ultrasounds that really takes a look at the baby from head to toe. Anything after that depends on medical history, depends on the patient's current status and where things are going in the future.
Now, it depends on like what your office is like too, right? I mean, we're kind of spoiled here that if I have a question, I can just move a patient to the next room and get an ultrasound, but not all offices have ultrasounds in-house. Right. So a lot of those officers are having to send their patients out for ultrasound. So that's not uncommon. And certainly those patients would have fewer ultrasounds throughout the course of the pregnancy because they're having to go to an imaging center.
Right. And so that's a great point to make. Not every facility is the same and has that same kind of flexibility, but 2 ultrasounds is what we're looking at. Things after that are sometimes to check on the baby. Now, the other flip side of it is if you have more ultrasounds than that, that's not a reason to be more concerned about the pregnancy. There may be certain things that the provider wants to look at and just kind of keep an eye on during the course of your pregnancy. And so that 16-week visit usually follows an 18 to 22-week visit is where you would have your anatomy scan. That anatomy scan is important because it really sets the agenda for the remainder of the pregnancy. It should be a very thorough review of the baby, looking at facial appearance, brain structures, heart, lungs, kidneys, intestines, bladder, really from a detailed anatomy standpoint, and then looking at features that are a little less glamorous, but still very much important during the course of the pregnancy, like looking at the placenta, umbilical cord, fluid around the baby, the cervix and the length of it. And so there's a lot of detail that goes into that. But after you have accounted for all of those things, things are pretty much in cruise control after that point in time. And it's a maturation process that takes place after that. And so...
And when we're talking about that anatomy ultrasound, the other thing I tell patients is that very often the ultrasound itself, the anatomy ultrasound, is done by an ultrasonographer, not by a physician. And depending on the personality of that ultrasonographer, they may be a very quiet type because they're not allowed to diagnose things, even though they probably know what they're looking at. But they're not allowed to say anything. So a lot of times as a patient, you're laying there watching it and it looks like they're measuring the same black circle, like over and over and over. And you're thinking, what is wrong? Like, why does she keep measuring the same black circle? They're different black circles and they mean something to her. But it can feel like you're not really sure what's going on. It can feel like there's something wrong, but that really is what the test looks like, that they're just measuring the same black circle over and over.
Yeah, no, I agree with you. Depending on your sonographer, there may not be a whole lot of explanation and a lot of beeping. Beep, 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 beep.
And they may not be chatty. So it may be, if their personality isn't chatty, then it can just feel like a very sterile concerning exam, but that is honestly what it looks like.
Yeah. Not at our office though.
No,
not our office.
I used to tell patients that all the time. And now I'm like, I don't really need to say that anymore because our ultrasonographer is very chatty. Yeah. You will have a lovely, wonderful, amazing, fun ultrasound.
From an office standpoint though, our office is great in a lot of ways, but usually after the anatomy scan, a provider will sit down with the patient and go over everything.
And that is important too. You will not leave this office until you know what was in that ultrasound.
Exactly. And so that's the good part about it, that you don't go home assuming that things are okay. We let you know things are okay. And then what the appropriate follow-up would be if things were not going in the direction that we thought for you. And so second trimester concerns. Now we're a little further along in the pregnancy. When do you think patients should come in for visits earlier than what's anticipated, or concerns that would certainly get a rise out of your doctor?
Would certainly make us worry.
Right.
Still bleeding. I mean, we always want to know if you have any bleeding. Sometimes it's not concerning, but we at least wanted to have the chance to take a look. Headaches, we want to know about. If it's your typical afternoon headache, I've been looking at my computer all day and I'm starting to get that tension headache kind of thing. Okay. But if it's a pretty severe headache and you take Tylenol and it doesn't go away, you need to call us. Yeah. You start seeing funny things. We absolutely want to hear about that too. One thing we hear a lot, and actually is not necessarily concerning at this point in pregnancy, is we'll have somebody call us, 20, 22 weeks and say the baby isn't moving. Yeah.
So that's a huge one. I'll let you finish up on that one, but yes.
I was going to say, so at 20, 22 weeks, we're not worried if you don't feel the baby for a day or two. At that point, the baby is still so little, and depending on where your placenta is, you may not feel a lot of movement. Now, we'll say something very, very different at 28 weeks, but at 20 weeks, if you feel the baby, amazing. If you don't, it's okay.
Yeah. And, that in-between time sometimes is a factor of, between feeling consistent movement and inconsistent. We usually have a rule of thumb that if you sit down and you have yourself a glass of orange juice or something like that, that's usually enough to kind of spark some movement out of the baby and give you some signs of reassurance. But if you haven't, certainly from an office standpoint, your office should be accommodating to let you know where things are in that regard.
I guess, I think I like the way you said that, because I still want you to call me if you're worried. I tell patients all the time, if this is going to keep you up at night, I want you to at least call me and ask the question. But sometimes I might say, that's okay.
Yeah.
It's okay.
That's fine. It's fine.
But if you're worried, call and ask the question.
Now, classes. When should patients start those classes?
The second trimester is the time, I think, to at least start looking for the ones that you want to take, especially if you're hoping to do an in-person one, because those book up fairly far out. So, if you have a particular hospital in mind, I would start looking right around the time of that anatomy ultrasound to see if you can get into one. I mean, you probably don't want to go until later, but you may need to start booking that early.
Yeah, the earlier the better if you anticipate that you want to take some classes. But you're right, the ones that are in person and even a hospital tour should be scheduled
for those
well in
that
advance.
Are still doing it.
Right.
They have really taken COVID as like their excuse to not bring those back.
Yeah, we're still dealing with COVID ramifications here.
I know. They're all online now.
Yeah. But it might be a virtual tour.
There's lots of virtual tours, and they are very, very thorough. I will say that.
So there might be a little bounce back, meaning that you'll have opportunity in person. But that's where it's important to kind of make sure that you're in line with, where your doctors will be delivering at the time, so that meets your expectations. I think we had mentioned this before, just kind of knowing the facilities and what each facility holds. It's become more and more popular for patients to want birthing tubs and things like that, but not every hospital will have that particular service. And so you got to figure out exactly where you're going to go and what facilities that they have once you actually get there. And so that covers a large stretch. There's one particular thing that happens just at the cusp of the second trimester into the third trimester. And that's that glucose testing, right? That glucola.
The dreaded glucola.
Yeah. And so, Kerry, in terms of experience, the glucose drink is not the only thing that they can actually take, right?
No, there are some choices. Yeah. The glucose drink itself, it's like drinking flat soda. Yeah. It comes in a couple of flavors. Usually your provider will have a couple of different options for you. But there has been a push recently to kind of offer more things. And there have been some studies done by ACOG, the American College of Gynecologists and Obstetricians, that I think that I have that reversed, don't I? Obstetricians and gynecologists. Yeah. That has looked into some alternatives, jelly beans. I think there was one with Twizzlers.
Yeah.
So there's some options out there, but please, if that's something that you want to do, that's something to talk to your provider about in advance, because the measurement of that is very, very specific.
That's exactly right. I am like the jelly bean king. Okay. If you want to take jelly beans as opposed to drinking the glucose test, and in a very similar way, I describe it like a melted popsicle. Mm-hmm. I've had it. That's what it tastes like to me.
It, huh?
Yeah, I did. I went out for the team. I said, let me try this. Why do people don't like this? And so,
and then you're like, oh, yeah. I get it.
So that's why I'm the jelly bean king, right?
Yeah.
I had to come up with some alternatives. But jelly beans, but you're right. You want to get the exact number right to meet really the gram load that you would require in order to have the test be on par with other kind of testing that you can actually do as well. And so we offer some different things within our office for patients to be able to do that. And so that's that glucose test. So the glucose test is really your screening test for diabetes during the pregnancy. Some offices may do that at certain intervals during the pregnancy, perhaps in the beginning. But the standard is usually to do that drink anywhere from 24 to 28 weeks along. That takes you right into your third trimester.
And that drink, there are some people that we have to do that early. There are very, if you meet certain criteria at your new OB appointment, you may be told that you have to do that drink earlier in pregnancy. Yeah. It's not unusual. And unfortunately, that doesn't get you off the hook for the 28-week test. You just have to do it again.
You got to do it again. That's sometimes a bear, but certainly worth it for the sake of the pregnancy. And just as we get into the third trimester for us, there are some vaccinations that we would certainly recommend. And Kerry, what are some of those vaccines that we would recommend for our patients?
So there's a few. Pregnant women are recommended to have the flu vaccine every year, whatever is the appropriate season. Yeah. So the timing of that during your pregnancy, it doesn't matter. In October, no matter how many months you are, you should get your flu vaccine. And then the Tdap vaccine, which we recommend between 27 and 36 weeks. It's, the goal is really the pertussis or whooping cough, which, while most of us, we wouldn't feel great if we got whooping cough. It can make babies pretty sick. Yeah. And it's one of those that if we get it to you early enough in pregnancy, then you would make the antibodies and those would go to the baby. So the baby is born with enough protection to get them through their first set of shots.
Yeah. So those are two great ones. Flu, certainly Tdap, strongly recommended during the course of the pregnancy. And generally, I recommend vaccines for anybody that's going to be intimately involved with the baby. So, of course, that involves dad.
Right.
He can certainly take one for the team. Certainly grandparents, I think it would be reasonable.
Absolutely.
To go ahead and get vaccinated. And then I typically recommend for patients to get COVID boosting during the course of the pregnancy. And then there's a newer vaccine that I think can be very helpful. And this vaccine is generally recommended after 32 weeks along in the pregnancy. And that's RSV vaccination, which stands for respiratory syncytial virus. RSV really accounts for a lot of childhood vaccinations, especially in the very early stages of life. And passing that immunity on to the baby can be very helpful.
And it's a tough one. So with Tdap, you can almost get away without it if you're going to breastfeed. If you're going to breastfeed, then you can maybe look at getting that one postpartum and get the protection to the baby that way. Same with flu, but RSV right now, if you don't get that before the end of your pregnancy, you wouldn't really be allowed to have it, because right now we only give it to pregnant women and older patients.
Yeah, with RSV, they're finding that it is most helpful for patients after 32 weeks, but up to 2 weeks prior to delivery, allowing your body to build certain antibodies to be able to be passed on.
Yeah.
And so from a timing standpoint, ideally, again, perhaps 2 weeks after or 2 weeks prior to delivery, can that be most helpful for patients? Now, there is something that you can give to the baby once the baby's born, but usually it's ideal just to go ahead and get mom vaccinated before everything takes place. And so now we move on to the third trimester. Now things are getting close for us. How close should patients be seen after approximately 28 weeks along in the pregnancy care?
After 28 weeks, we start to see patients every 2 weeks. Yep. And it starts to feel like it moves a lot faster once you're in the doctor's office every 2 weeks. And not right around then, usually a little bit later. You should also be prepared to leave a urine sample every time you come to the doctor, because we'll be checking that every time. And sometimes we won't let you leave.
Yeah, that's right. I'll hold you hostage.
Because it really is that important. So that's something to keep in mind, because that's sort of new at that part of pregnancy. Yeah. But every time you're here, we will always check your vital signs, your blood pressure. We'll ask you how you're feeling. After 28 weeks, we're also going to ask you, are you feeling that baby move every day?
Yeah.
Because unlike earlier in pregnancy, if you're not feeling that baby move every day, we want to know. Yeah. So we'll ask you if the baby's moving every day. We may even start to tell you that you have to do something called fetal kick counts, and we'll want to know about those when you come into the office. And we'll start checking the baby's heartbeat. Of course, we'll continue checking the baby's heartbeat with every visit. But we'll also start checking the position of the baby, and that's sort of new at that point in pregnancy.
Yeah, most offices will see you after 28 weeks along in the pregnancy, anywhere from 2 to 3 weeks in intervals. And so most patients will come back at 28 weeks, 30 weeks, 32, 34, 36. But by the time you get to be about 36 weeks along in the pregnancy, you'll be seen weekly. And sometimes even more frequently than that, depending on what's going on and what's happening during the course of the pregnancy for you. And so 36 weeks now, the pressure's on. We got a month to go. And so this is the time where I think it's appropriate to discuss, birthing plans, if that's what you have in mind. If you don't, that's okay too. And the last bit of testing will take place at 36 weeks. And Kerry, you often do this test. So what should they expect at 36 weeks?
So at 36 weeks, you may, depending on your history, you may actually have a little bit of blood work. If there's anything that we're continuing to follow, if we found that your blood counts were low at some point in pregnancy. So it's not unusual for us to get some blood work at 36 weeks. But what most people are familiar with are the swabs. So we get a set of vaginal swabs at 36 weeks. Yeah. And we're checking for a couple things. You get tested again for gonorrhea and chlamydia. You were tested at the beginning of pregnancy. You'll be tested again at 36 weeks. And then the one that more people are familiar with is the group B strep, which I always tell people gets a terrible rap because it's thrown in there with gonorrhea and chlamydia. Yeah. And I've gotten some very ugly phone calls from my poor 37-weekers who think now they have some horrible disease because they tested positive for group B strep. But women are just silent carriers for this bacteria. It doesn't necessarily cause us any trouble. We really don't test for it at any other point in your life. It can just be in the vagina. But we have found over time that it can make babies really sick if it's there when it's time to give birth. So we test everyone at 36 weeks.
Yeah, I think it's important. And it really doesn't need to be treated at all, like you were saying, until the delivery is getting ready to take place. Prior to that time, even if you're positive, some patients will call and say, well,
should I be treated now?
Can you go
ahead
and just give it to me now? I mean, and I can do it again in labor, but it really doesn't serve any purpose for mom because it doesn't necessarily impact mom to a significant extent. But as the baby comes down the birth canal, that can be a different situation for us where treatment certainly would be appropriate if you're positive. That's also the time as things kind of get closer and closer where you discuss labor plans, what to do, where to go, when to go to the hospital, when not to go to the hospital. And, there's really 2 reasons, or perhaps maybe 3, for you to go to the hospital and to be evaluated. And one of which is, of course, labor. Okay. And so what's
our
labor?
favorite reason?
Yeah. What's labor though? So we got to really define this labor thing. What's because some people think they're in labor, but they're not in labor. So what's labor?
Every now and then you get the one that didn't realize they were in labor.
Oh,
but really, they clearly were. That's less common. But so we're looking. The first thing we're always going to ask you about is contractions. Are you having contractions? Yeah. And starting 34, 35, 36 weeks, people can start to have cramping, and cramping can be uncomfortable. And I don't want to dismiss it because it can be starting the process, but it's not the same as contractions. Yeah. Contractions really have a pattern to them. And I tell people, like, you've seen it on the movies where you look at the strip and they go up and they go down like hills, but they feel like that too. Yeah. You'll just have this sense that something is coming, and it'll get stronger, stronger, stronger. It'll reach a peak, and then it'll ease off and it'll go away and there'll be nothing. Yeah. And then a few minutes later, you're like, wait a minute, what's that? And it'll come back and it'll get stronger, stronger, stronger. It'll reach a peak and it'll go away. So that's what we're really looking for when we're asking you if you are having contractions. Because there's Braxton Hicks, which can last for minutes and minutes and minutes. Yeah. And they're not necessarily uncomfortable. It's just weird. It's like you're doing a sit-up, but you're not doing anything. Like all of a sudden everything is tight and you're like, well, this is really strange. But the contractions, initially you can feel them in all different places, but as they really start to pick up, they tend to kind of start at the top of the belly, wrap around the belly. And some people, they'll go into the back or down into the thighs. But more important than anything else, no matter what you rate it on a pain scale, all I really care about is that pattern. Yeah. If they're coming and going regularly, you need to start timing them, because that's what we are watching for.
Yeah. And I try to give patients advice to prevent the false alarm or false labor, because that's frustrating. I mean, because
coming in here is bad, but going to labor and delivery and getting sent home, even when they're lovely about it, and they often are, it's so demoralizing. It's defeating. It's so hard to get home. It's so hard to get sent home from labor and delivery, even though, trust me, they do it all the time. Yeah. They did not think anything of it, but it's really hard to get sent home. I'm not speaking from experience at all.
So I generally have a rule for patients that I think is a pretty good one. It's the 5-1-1 rule. That means you should be contracting every 5 minutes for at least 1 hour. And those contractions are generally 1 minute in duration for us. And so so we're not contracting for 5 minutes. Yeah. I always tell patients, I'm like, when I say the contractions are 4 to 5 minutes apart, we mean from the start of one to the start of the next. That's right. That contraction doesn't last for 4 minutes. That's right. And you know what, Kerry? I can almost tell immediately who's in labor and who's not.
Okay, by looking at them?
Yeah. If I can look at you and you are not even wincing, probably not in labor. Matter of fact, I can even tell before I even get to the hospital. If I get a phone call from the mom, then you know what? I guarantee she's not in labor, okay? If I get a call from the dad, there's a strong possibility that she's in labor, because we do want those contractions to be uncomfortable. As a matter of fact, I will say to patients, you should never be able to time your own contractions. Okay.
Also, I think it's a really good job for partners.
Yeah, but of course.
I mean, I think one of the toughest things has got to be, I don't know, because I've never been in this position, but I imagine one of the toughest things about being a dad is just like standing by and watching this and not having anything to do.
Right.
I tell my husband all the time, I'm like, it's got to have been hard because you guys are built like you just want to fix a problem and you can't fix labor. You just have to watch it. And that's gotta be tough. That's hard. So I'm like, give him jobs. Like teach him how to do massage. Let him time the contractions. Like jobs are good.
We're good. That's right.
Jobs are good.
Yeah, so he's timing the contractions for you. So we talked about contractions and labor. There's another biggie too. Did my water break? What is
Which is not always easy to tell, right?
Yeah.
I'm like, please don't be embarrassed when you're calling and you're saying, I'm not sure if my water broke or if I'm peeing on myself, because it happens all the time. Yeah. It can be hard to tell. Sometimes you get lucky and your water breaks and you're standing in a puddle and there's just no question. Yeah. But sometimes it's a much slower leak and you got to ask the question whether you come in to see your doctor or you go to the hospital, but it can be harder to tell.
So that's where, the advice from your provider, but I usually tell patients right around that 37, 38 week visit, what does it mean for you to break your water? When the water's broken, there will always be a continuous level of flow.
Yeah.
So if anytime you're questioning about it, because sometimes that baby can just do a karate chop to your bladder and you have some leakage and you're like, I don't know. But if you dry yourself off and then an hour later, there's some more leakage, then there's a strong possibility that your water broke. If you are bone dry in an hour, well, guess what? You probably did not break your water. And so it's a false alarm for you. So
We won't discuss the alternative.
No, not at all. Yeah, exactly. So
I always tell people, I'm like, just when you think there's not a moment that you could lose any more dignity in pregnancy, we'll find something.
Oh no, all modesty's gone. It's gone. It's gone. And so, so those are the two primary reasons, patients would go to the hospital. The third one, and of course there can be plenty of others, but usually there's some concern about movement and how the baby's doing at the same time. And if you can't get that stimulation that you normally would get, even after you've done your fetal kick counts and things like that, that's certainly a time to at least discuss it with your provider.
Did you know there's an app for that?
There's an app for everything.
I know. There's a fetal kick count app. Count the kicks. It's fantastic. It's free.
Oh, well, we got to download it.
I know, right?
Speaking of which, that
also, we're not sponsored by them.
No,
just to be clear.
We didn't mention any names. Well, that kind of summarizes our expectations and things for really the beginning to the end in terms of pregnancy for you.
For a really normal pregnancy course, there can be some variation, but any variation would be discussed with, you would be discussing that with your provider.
Exactly.
And they'll explain why they're changing you from the norm to anything else and what those expectations are.
Well, thank you everyone for listening. Moving on to the next.
Thank you for joining us on this episode of STIRRUPS. Be sure to send us your women's health questions and topics you'd like to cover by visiting our website, carolinaelitewomen.com. If you enjoyed today's episode, please subscribe to the podcast and spread the word by sharing it. To find out more information about Carolina Elite Women's Care, visit carolinaelitewomen.com. This podcast is edited and produced by Earfluence. Stay healthy and stay empowered. We'll talk to you soon on STIRRUPS.